Welcome, dear colleagues from around the world, distinguished panelists and friends, to the virtual meeting of the Global Multisectoral and Multi-Stakeholder Platform to End TB. We are very pleased to see over 130 people joining us. We had over 450 registrations. So yeah, we look forward to more people connecting. This event is also being streamed live on our YouTube channel, so you can watch it there and it will be posted on our website. So thank you so much for your interest and joining us today. This is a very important event for us all to take forward the work that we are doing on multi-sectoral engagement, action, and accountability. To start off the meeting, I'm very pleased to introduce my director, Dr. Teresa Kasaeva. She heads the Global Tuberculosis Program at the World Health Organization, and she will be opening this meeting. So, Dr. Kasaeva, over to you.
So, thank you very much, Monica. Dear colleagues, partners, friends, good morning, good afternoon, good evening. We see that you've connected from different regions and time zones. We do appreciate your time, your commitments, and your dedicated hard work in different regions, sometimes in extraordinary circumstances, unfortunately very unpredictable. And it's great to see that we are all together and at this important global multi-sectoral and multi-stakeholder platform to NTB coordinated by WHO. We are receiving frequently questions, so is it the best time for TB to highlight TB, to address TB? And the response is obvious for all of us. Yes. It's the right time, and we cannot postpone our steps, our fight against TB, because TB remains one of the biggest infectious disease killer in the world, and killing 1.5 million people. And unfortunately, we can see the increase in deaths for the first time over the past 10 years, and it's extremely concerning. It means that we should double, triple our efforts, that we should use new innovative approaches and multi-sectoral actions to strengthen our response to TB and our fight against TB. TB is everywhere, and we know that more than a quarter of the world's population is infected. But in the same time, it's also well known that TB is mainly concentrated in settings beset by poverty and other social and economic challenges in the most vulnerable populations. And we can unfortunately see it's very clear in the areas and zones of conflict and war. And we're deeply concerned about this situation. Progress towards ending TB cannot be reached only by health system and medical measures. We should go beyond our traditional efforts done mainly by TB programs. We should go beyond even health sectors, and we should reach other sectors following the principles of SDG, WHO Global Action Plan, and to bring them meaningfully and unite in the fight against TB. The importance of this multi-sectoral approach has been a cross-cutting theme in political commitments to end TB since the development of WHO's anti-TB strategy. It was again highlighted and reinforced during the first ministerial conference of WHO in Moscow. Then we've seen strong commitments in the political declarations of the 2018 United Nations General Assembly high-level meeting on TB, included commitments by member states to develop and implement as soon as possible multi-sectoral accountability mechanism. WHO, following this request, developed and rolled out WHO multisectoral accountability framework. Now it's well known as MAF-TB, to accelerate progress and to explain what could be the mechanism, because it's a quite popular topic in many areas, the multi-sectoral engagement, but probably it's for the first time when we're coming with a concrete mechanism and trying to explain all the details, how this mechanism should be developed, who should drive this mechanism, what are essential elements, and how it should work in practice. Yes, it has been developed, followed by a MAF checklist, and all this work was done in close collaboration with partners, with the TB programs, with the civil society, and we're very pleased to see this meaningful contribution. Further following the request, we are now working on the operational guide and best practices document. In the same time, in parallel, we're very happy to see that many countries and regions are quite advanced, and I see here representatives of these regions who are moving forward using different additional instruments like patient cost surveys, trying to find answers to the questions. What are the key determinants? What are the key social bottlenecks and barriers that should be addressed and prioritized to really provide further progress towards ending TB. At the global level, WHO launched a collaborative multi-stakeholder and multi-sectoral platform to coordinate TB response and review progress. We have engaged at various levels and we're having regular events since the launch of this platform, and looking to strengthen and formalize our efforts more to advance these actions and accountability. This meeting is another important step, and actually we would like to highlight that maybe we open a new phase in our marathon towards second high-level meeting on TB, which will be in 2023. Faster actions, more concrete actions should be in place, and in this very dynamic world full of challenges, we cannot do business as usual. So that's why we will try from our side to guide, to share these best practices and experiences to answer your questions. Please join us and use this platform and mechanism to receive answers to your questions. So we look forward to your active participations in today's meeting and further collaboration. And I do believe that despite of all the challenges, we have still opportunities to address the needs of the most vulnerable people with TB and their families. And with this intention, let's drive further TB agenda together, and we can make the difference. It's really time to end TB. Thank you very much, and I wish you all a successful event. Thank you.
Thank you very much, Teresa, for your inspiring opening address. It's very much appreciated, and it indeed sets the tone for the meeting. So I'd now like to turn to Blessy Kumar, who is who is a member of WHO Civil Society Task Force. She also heads the Global Coalition of TB Activists. She is a well-known civil society leader for the past many decades, and we're very pleased to have her with us to share with us in this opening session the civil society and survivor perspective on advancing multi-sectoral engagement and accountability. So over to you, dear Blessy.
Thank you so much, Monica, for that introduction, and thank you, Teresa, for this opportunity. Good evening, everyone, and I'm very grateful for this opportunity and for this space to bring civil society and affected community perspectives to this global platform for multisectoral accountability framework discussions to end TB. The past 5 years, there has been very encouraging progress in terms of commitments, at least. The first ever UNHLM on TB, where world leaders made unprecedented commitments. The UNSG report 2020, which had addressing stigma and discrimination, removing human rights barriers as part of the top 10 recommendations. Extremely impressive. People-centered, rights-based TB response has become the buzzword. And it's really encouraging to see countries including this in their national strategic plans and attempting to implement it at the ground level. All this brings much hope for the TB-affected communities. However, the reality is a bit different, as we all know and as we all would agree. The multisectoral accountability framework is cross-cutting. And the World Health Organization efforts in making this framework work at the global, regional, and national level, along with active inclusion and partnering with the civil society and TB-affected communities, is something that all of us in the Civil Society Task Force are extremely proud of. Having said this, the reality is that the real action is and always will be at the country level, at the ground level. World leaders and heads of state can commit, donors can fund, WHO can develop guidance documents with inclusion of all stakeholders, but the action is at the country level. And this needs a robust, capacitated civil society and TB-affected communities to ensure that these high-level commitments become a reality for those affected by TB. Now, this needs to be supported, this needs to be funded, and made into a formal mechanism. WHO country offices need to recognize this and respect the affected community perspectives. We know that TB is concentrated in settings beset by poverty and other social and economic challenges, and in the most vulnerable populations, as the background document to this meeting states. So what are we doing to address things like this? We need to consider what are the steps that can be taken. Who are the different players to address this? What sort of guidance is available for implementing this at the country level? Do our accountability mechanisms take this into consideration? Addressing the drivers of the epidemic should be our priority. As we, the advocates and the affected communities, have been saying very loudly, clearly for a very long time, that only a medicalized approach will not end TB. Now, accountability will only make sense when there is action. Otherwise, who is accountable to whom and for what? So it's perhaps an AA. No, I don't mean the Alcoholics Anonymous. I mean accountability, action have to go side by side, hand in hand. And we also need to recognize that ultimately, all of us are accountable to those affected by TB. TB that is preventable and curable. So on behalf of the TB communities, I sincerely hope that soon we would not have to start our documents with the sentence, despite being preventable and curable, tuberculosis remains one of the top infectious killers in the world. To this end, Let us work with renewed commitment, passion, and hold ourselves accountable as we discuss the multi-sectoral accountability framework. I wish the discussions a people-centeredness and hope that our collective dream of ending TB becomes a reality in the near future. Thank you.
Thanks so much, Blessy, for your passionate remarks. Indeed, action and accountability need to go side by side. And we hope that this platform sets the tenor for this direction and the way forward. So thanks so much for that, Blessy. We'll now move on to the next part of the opening. I didn't introduce myself at the start because I wanted to introduce myself now as I begin my presentation. So I'm Monica Diaz. I'm with the World Health Organization Global Tuberculosis Program. For those of you who don't know me, I lead the work at the Global TB Program on multi-sectoral accountability, on TB elimination, on the DG flagship initiative, Find Treat All, as well as on public-private mix or public-private partnerships, which is also closely linked to the work on multi-sectoral engagement. It is indeed a great pleasure to be here, and it's very heartening to see it's very heartening to see that we have over 200 people connected. Thank you for joining us here today. So what I'm going to do is take you very quickly through our work on advancing multi-sectoral accountability and give you a quick overview of progress and key tools. I won't repeat everything that's been said, but just again, very quickly flag why it's important. Of course, TB remains the second top infectious killer. Millions still miss out on access to both care as well as preventive treatment. 9.9 million people fall ill with TB each year. Again, just quickly reminding you of statistics. And again, TB is not just a medical disease. There are many social determinants, different factors that affect it, which spread out beyond the SDG, the Sustainable Development Goal on health, but across all the 17 Sustainable Development Goals that we have. And this is also very clearly seen from our report, where you can see that the TB cases are the people who fall ill with TB are attributed to several risk factors, including undernourishment, alcohol use, diabetes, and it goes beyond. So there are many social drivers, as both Teresa and Blessy have already pointed out. We have global commitments over these past many years. All of them have touched upon the importance of multi-sectoral engagement, from our End TB strategy on to the Global Ministerial Conference on Ending TB that took place, where multi-sectoral accountability and the framework was first conceived, to the UN high-level meeting in 2018, followed by the development by WHO of the multi-sectoral accountability framework. And it was again reiterated in the UN Secretary General's progress report on TB in 2020. And we've been flagging this throughout in all of our political dialogue, in all of our key events, including this year at our online talk show. At WHO, of course, multi-sectoral engagement has been a major priority for us. It's a part of our general program of work, the triple billion targets. Health is, of course, at the center of all SDGs, and WHO is leading the work through our global action plan. And I've already mentioned our NTB strategy. And our Director General, of course, prioritizes ending TB in the context of, universal health coverage and health for all. So just to remind those who've connected, who are new, this is our WHO multi-sectoral accountability framework. It has four components, from commitments, actions, monitoring, and reporting, to review. And you can very quickly take a look here at the different the different components, and you're welcome to read the document for more information. We will provide you with the links in the chat. So here, very quickly, are some of the requests to WHO from member states for MAF implementation. MAF-TB is our multi-sectoral accountability framework. We abbreviated to MAF-TB, so just reminding you all. Again, we've been requested as part of the World Health Assembly and in the political declaration to support member states with stakeholders in national adaptation and use of the framework. We are leading and promoting collaboration through our platform, and including through civil society, with the engagement of civil society and affected communities through our civil society task force, for instance. We've been working closely with several UN agencies, with the private sector, and several other stakeholders. Several tools have been developed that I will go through in a bit. We are supporting baseline assessments, which are really the foundation for any implementation efforts, especially on multi-sectoral engagement. We have, as part of doing reviews, we have joint missions, program reviews, as well as global stock taking through our report, through the World Health Assembly, through the UN General Assembly, etc. And we are supporting national consultations and the development of mechanisms in countries on MAF-TB. Now, this meeting, of course, is a convening of the global multi-stakeholder and multi-sectoral platform that we launched back in 2019, along with our initiative on youth engagement. We have been taking this forward through various mechanisms, but we're really looking, as Teresa said, from this point on, given that we are in the lead up very close to the next UN high-level meeting, to really take this a step forward, to have more engagement, to advance the work that we are doing. We, as far as tools are concerned, we've developed baseline assessment checklists with annexes on ministerial engagement, civil society engagement, and guideline adoption. All of this, which is included, and several countries are using this. We will share information with you in just a bit. In terms of global review, our global report is where we are collating all information, including on various social determinants and drivers. We also have developed a MAF-TB operational guide. Very quickly, here is the structure of it for you. We are now in the process where we've developed the document. We've shared it with key stakeholders for inputs, including across all three levels of WHO. And we are now in the final stages of getting this guide ready. And the next step is really going to be implementation. But you can see very clearly here, we have a strong introduction with giving the background, the rationale, again, reiterating the various components of MAF-TB, and we have, key guidance on adaptation and use at national, including the local level, with examples of roles of sectors and other stakeholders, associated performance indicators, and we are also looking at the various components for MAF-TB implementation and sustainability. So please do keep your eyes peeled. This operational guide is coming out. Along with this, we will also be putting out a best practices document on MAF-TB, which will feature very strong case studies that have been contributed from the overall community. Many thanks to those who have contributed case studies who are connected with us here today. Now, very quickly, looking at progress on MAF-TB implementation, which comes from our global TB report. 157 countries, including 29 high burden countries, have published annual reports on progress. There are national mechanisms for high-level review, um, on MAF-TB established in 125 countries, including 19 high-burden countries. Civil society and affected communities are actively engaged in the MAF and review process in 87 countries, including 15 high-burden countries. We've done an analysis of the MAF-TB baseline assessments. An analysis from 45 countries indicates that all 4 components of MAF-TB are in place in 17 countries. 30 or 45 countries have translated SDG UNHLM targets into national policies, which is a key step. 15 countries have formalized national multi-sectoral coordination mechanisms, while 25 have updated their strategic plans with MAF-TB. Again, very important as you're looking at implementation. 40 countries have strong TB surveillance systems and are reporting annually to WHO on MAF-TB. Going ahead on the assessment, again, now looking a little bit at what needs to be strengthened. 36 of the 45 countries do not have high-level leadership engagement for the periodic review of the TB response. This needs to be strengthened. And in about half of the countries, there need to be more clearly defined lists of accountability beyond the health sector. There needs to be a stronger budget, and civil society needs to be engaged across all the 4 components of MAF-TB. We do have, as many of you know, WHO MAF-TB network platform as part of our interactive web forum, NTB forum. If you are not a member of this platform, you can easily connect by scanning, using your camera on your phone, scanning the QR code or accessing the link provided there. My colleagues will post the link also on the chat. You're welcome to sign up and be a member of this interactive platform where you can share information, share best practices, connect with other people who are also involved in MAF-TB implementation. So this is going to be really important. Furthermore, so looking ahead, what are our key priorities? Of course, one of our biggest priorities is going to be leading and coordinating the preparation for the 2023 UN high-level meeting. This is one of the roles that WHO has been assigned, including the supporting comprehensive review of progress. Finalizing, as I have already said, we are looking at finalizing and launching the operational guide and best practices document. We plan this year to organize several trainings and webinars over this year and the next to really ramp up implementation of MAF TB. We are available to support regional and country MAF TB initiatives, so please do feel free to reach out to us in case of support. Further intensify engagement of key stakeholders. This is what we want to do through this global multi-stakeholder and multi-sectoral platform. And I've already shown you our online MAF-TB network. We urge you to join us and be part of it. So coming to our agenda for today, it's very comprehensive. You've already heard from Dr. Kasayeva, from Blessy. I've presented a very quick overview, and my colleague Liana will present the meeting objective next. We will then have an opportunity to also, take a snapshot or a group photo. We'll then go into a spotlight session with countries on multi-sectoral collaboration and accountability, and you can see it's quite a packed agenda with experiences coming from Brazil, China, South Africa, and Europe and Central Asia. So very interesting. We'll keep it very interactive, and we ask you to post your questions using the Q&A function as you listen to the various presentations. The country spotlight will be followed by a multi-stakeholder panel on advancing multi-sectoral and interagency collaboration to end TB. And here we've again got a very distinguished lineup of speakers from the International Organization of Migration, the International Labour Organization, Stop TB Partnership, and WHO Civil Society Task Force. This will be again followed by an interactive Q&A through through the Q&A function, followed by a poll using our online platform, and we'll then conclude with an overview of steps and closing remarks. So that very quickly is an overview of our agenda for today, but we'd like to keep it as interactive as possible. I'd now like to turn to my colleague, Liana Oganozova, who's part of our team here on multi-sectoral engagement and accountability, to present the meeting objectives. Over to you, Liana.
Thank you, Monica. Greetings to everyone. I would like to present the meeting objectives, and the first one is to convene WHO's collaborative multi-stakeholder and multi-sectoral platform on ending TB, to review progress, drive accountability, and coordinate the TB response. Next objective is to discuss WHO's upcoming operational guidance for country adaptation and implementation of MAV-TB, and share country examples on multi-sector collaboration, and as well as experiences on adaptation and implementation of MAV-TB at national and local levels. Also, we'll discuss ongoing efforts by development partners to strengthen and operationalize MAV-TB at all three levels, and check the way forward and discuss actions needed to scale up MAV-TB implementation at country level. These are the main objectives. Thank you very much, and hand over back to Monica. Thank you.
Okay, thank you very much for that overview, Liana. So with that, we come to the end of the opening session. So it's been very comprehensive, and you have a strong base from which to move ahead to the next discussions. Before we move to the next session, we have this little pause in between. And I'll turn to my colleague, Wongi, who's also a part of our team here at WHO, to take us through the next part. Over to you.
Thank you, Monica. Warm greetings to all the distinguished speakers and our participants from all over the world. As I can see now, we have over 200 participants. Actually, it's nearly 230 people who join us live now. Please allow me to invite all the speakers to kindly turn on your camera and to let everybody can see your faces. That will be really, really grateful. Please, all the speakers and participants, to turn on your camera, please. So we will, thank you so much. Now we can see our participants here. So I would like to take a quick snapshot for all of you to mark your participation for today's important meeting. I would say let's end TB, and I would love to see everybody have a confident smile. Thank you. Let's end TB. Just try one more. Let's end TB with a confident smile. Thank you so much. So for all the participants, like 230 friends from all over the world, now I would like to invite all of you to join me for an interactive section. As here you can see through this screen, there is a QR code on the right hand. You can use your mobile device to detect this QR code and to join us online. And also, if for anyone who are joining us through a web page, there is a website, slido.com, and you could also enter the passcode MAV-TB to join us. So here, I would love to see everyone. Please let us know your name and which country are you joining us from. Now we can see Monica's entering her name and from Switzerland. Thank you. We can see our friends from Pakistan, UK, and wow, is joining us. We have people are ranking from everywhere, I would say. Thank you so much. Please keep this poll rolling, and we would like to see all of you joining us. And we will keep this poll open. Let us know your participation. Thank you. Now I will hand over to Monica for the next session.
Thank you so much for that, E, and greetings to all the colleagues from across the world, from Indonesia, Uzbekistan, Nepal, Ukraine, Netherlands, Papua New Guinea, India, Pakistan, Mexico. I mean, the list, Nigeria, Canada, the list goes on, Cambodia, very, very impressive group. We are very appreciative of you joining us here today. We cannot have your picture, especially as attendees, but this gives us a very good snapshot of who is joining us today, and we'll put it together as a cloud collage so that we can see you here with us. So thank you for joining us. Now, before I go to the next session on the country spotlight, I'd like to first draw your attention to another poll, since many of you are on Slido. Now, throughout this meeting, you're going to hear about experiences from countries on how they're implementing MAF-TB. You will hear from partners on their work in engaging across sectors and potential for collaboration. And what we'd like you to now respond to in the poll as you're listening is, what in your view or experience is an important priority to facilitate MAF-TB operationalization? And we'd like you to list your name next to your response so that when we come towards the end to the interactive panel, we'll have an opportunity to call on you as well. So we'll keep this poll open. I see people are listing their names here, but we'd like you to use this poll to really let us know what your priority, what you think is an important priority to facilitate MAF-TB operationalization. So without further ado, now we'll stop this. We'll keep it, we'll send you the link on the chat, but now let's just go to the next session. We'll keep the poll open for you to be able to comment, and as you listen, to think and to give us suggestions. So the next session is a country spotlight on multisectoral collaboration and accountability. And I'm very pleased that we have with us our co-chair, Martin van den Boom, who's the regional advisor for the WHO Eastern Mediterranean region. Welcome, Martin. Great. So he's co-chairing this session with me. So Martin, of course, is working with us very closely for the past, I think, over a decade with us, and the Eastern Mediterranean region that he is heading on TB is also doing a lot of work, interesting work on multisectoral engagement and accountability. So thank you, Martin, for joining us and for co-chairing the session. I'll let you introduce the session as well as introduce the speakers. So over to you, Martin.
Thank you very much, Monica, Teresa, colleagues, friends, passionate TB fighters around the world. It is my pleasure and my honor to co-chair this session with you, Monica, today, this afternoon here from Cairo. And yes, the session, and now after this initial introduction to the concepts and overview and the progress and also the objectives of this event, we shall be going into the examples from some selected countries and also region. And of course, there are many others we cannot feature all, but it is really a very interesting set and of examples from different parts of the world. So I'm very much looking forward to this session myself and be happy to learn also from all the examples and hopefully be able to replicate some and also for the examples in our region. So the session, as you will see, is structured in a way that we will have 4 presentations. And throughout the course of it, colleagues and led by Monica will be able to monitor the question and answer chat function. So after those 4 presentations, we will have also time to answer, or those who have presented will have time to answer some of your questions live. So the presentations will be about 6 to 8 minutes each, and then we will have half an hour for the actual question and answer session. Again, please be very proactive and engaged also in posting your questions throughout the course of the presentations. So without any further ado, I'm delighted and honored to announce Dr. Isel Maciel from the Brazilian TB Research Network, and we'll be happy to hear from you and your experiences with MAF implementation in Brazil. The floor is yours. Over to you, Ethel.
Thank you, Dr. Martin. Thank you, Dr. Monica and Dr. Teresa. I will share my presentation here. Hope everybody's seeing this. So I'm going to talk a little bit about the Brazil experience and about the very quick about the survey, the patient cost survey research and what drives us to the MAF experience here. So we went in all over Brazil in the middle of the pandemic, because when we started the survey, the pandemic came along. So we interviewed 63 patients, and we have DSTB and DRTB. The catastrophic cost in Brazil is 48%, so it's very high, and it's most high in DRTB, as expected. A little bit different of other countries, as Brazil has a universal health coverage. The most important, what drives to the catastrophic cost is the income loss, most because the patient is unemployed or self-employed, and when they go to the health service, they lost the income. They don't have like labor protection, and this is a big problem in the TB patient. This only very quick to see that the most important in a multivariate analysis is the HIV status and the self-employed, because they don't have like the labor protection in the most part of these patients, more than 50%. And as in Brazil, as in the other countries, the level of education, it's very close to economic status. When you have the most high education, you are like most protection, have more protection with the catastrophic cost in Brazil. So a lot of these patients don't have social protection for any kind, and this is a big problem. For this survey, we have like 4 major areas of actions in Brazil. Some in the health service and others in the other service, other sectorial, not in health. So we need to improve our service for TB patients. We have a lot to do in Brazil. Patients come to the clinic because they have side effects, because they have HIV. The HIV clinic usually is very far from their home, so they need to travel, they need sometimes to another city to see a medical doctor, a specialist in HIV disease, so or in AIDS disease with TB. So we need to spend very few service, and it's not very difficult to do this. We need to integrate TB and HIV health service in the same clinic, because right now they are not in Brazil. They have to go to the TB clinic and they have to go to HIV clinic. So they have to go twice or 3 times for one episode of the disease. We need to expand the vitamin B6. We don't give for all patients in Brazil, so they have side effects. They need to go to the clinic a lot of times, and they don't have money to do this. We don't have vouch transport for their patient. We need to decentralize the access to TB treatment and LTBI, diagnosis and treatment in Brazil. And we need to use like digital technology that in Brazil are not a reality. So this is very, it's not complicated to do, but as our colleague Blessy told us, we need investment to do this. We have the new short regime in Brazil right now. They are starting, so this is a good news. And for this, the digital technology, we don't have, I will talk a little bit in the other slide, we don't have in research, we don't have in the field for all patients yet. We need to make TB as a criteria for social protection program in Brazil. They are not yet. We need to have food basket and transport voucher for TB patient, because they need to go a lot of times to the TB clinic and they don't have money to do this. And we need to enhance the labor protection. A lot of this patient, especially DR patient and HIV patient, they have associate problem that they cannot work in the same job that they do before they have this disease. So they need a new preparation. We need a new program for this patient to have to go to the labor market again. And we have this very brief. We have right now some digital initiative in Brazil, but as I told you, it's only still is a research, and we don't have in the health service as for all patients right now. I'd like to say my welcome to my colleague from the NTP, Dr. Chen, that is here too. The NTP in Brazil made a plan, a strategic plan to NTB from 2021 to 2025, and it was before the national catastrophic cost survey. So these indicators are not in the plan right now, so we need to discuss in this. They did a public hearing in 2021 in the National Congress on TB response. We have a cooperation agreement that was signed between the Minister of Health and the Minister of Social Development to enhance the social protection. We have also a cooperation agreement with the Minister of Human Rights and to fight against the stigma and discrimination. And we have for the first time a financial support to the community committee for monitoring research on tuberculosis in Brazil. So this is very, very good, and we have some good news from Brazil. But the next step, we need to start using digital health apps to the monitoring TB treatment and diagnosis and treatment. As I told you, it's still just research. And we need to the national strategic plans to include strategy to mitigate the economic burden for this patient, because they are 48% are suffering for this. And we have to monitor this indicator for the next survey in 2025, that we hope we have better indicator. But as I already told, what we have right now is commitment in Brazil. We have a lot of commitment, and we need to go to the next step. We need to be funding to have this commitment in action, right? Right now, we still missing the action for the TB patient on the field, on the health system. So thank you very much. And I'm here to answer your question. Thank you. Thank you for the opportunity.
Thank you so much, Ethel. That was indeed an excellent presentation. Very, very, very comprehensive. And it's very clear from your presentation and the work that you've done, on the patient cost surveys. It very clearly points out to the need for engagement across different sectors, as you pointed out, with social development, with labor, to address the issues around poverty, undernutrition, etc. I'd just like to flag, as Teresa has reminded me, that we've that on the WHO website, this case study that Ethel has presented it's been showcased as one of the best practices of 3-level collaboration from country, regional, and headquarters, all and global level collaboration to really address this issue of catastrophic costs faced by TB patients. So this is really a very impressive success story. Thank you so much, Ethel, for this presentation. I'll turn back to you, Martin.
Thank you very much, Ethel. I'm seconding Monica strongly. And thank you, Monica, also. And I'm happy to announce the next speaker without further ado, which is Dr. Songdong Chen from the WHO Country Office of China. And he will be providing us with the math implementation example from China with the focus on lessons learned and way forward. Dr. Songdong, the floor is yours. Over to you. Thank you very much.
Can you hear me?
It's a bit distant. Maybe you speak, can you speak up? But I think you are well audible. Try again, please.
Can you hear me?
Yes, very well now.
Yeah.
Excellent. Go ahead.
Dear Teresa, dear Chair, ladies and ladies, it's my great pleasure to present and share lessons learned of implementing multi-sectoral accountability framework for TB in China and the way forward. Historically, China has been paying particular attention to multi-sectoral engagement and the whole society participation in health agenda. The guiding principles of TB response in China are summarized as people's health at center, gave priority to prevention and combine treatment with prevention based on scientific evidence and notes. And all sectors take respective accountabilities with the whole society's joint effort. Focus on the priority, take into consideration of local context, and provide categorized guidance and integrate TB control and work with poverty reduction and deepen health reform. Under these principles and in line with global multi-sectoral accountability framework with aim to fulfill the commitment to SDG, United Nations high-level meeting on TB, and to achieve the TB control targets set in the national health agenda. China takes concrete actions in developing and implementing multi-sectoral participation and accountability mechanism, including defining the clearly responsibility for relevant departments and sectors, setting up an inter-minister joint meeting mechanism on the prevention and control of major disease chaired by Vice Premier of State Council as the coordination body, renewing TB management information system by strengthening the linkage with National Health Information System. This is the actions to enable effective monitoring and reporting of multi-sectoral action on TB. Strong information system were established with components of TB case reporting, TB patient management information system, TB deaths registry, national death cause surveillance system, sentinel surveillance for drug resistance, and ad hoc surveys on financial burden of TB patients. Together, this information system can connect and provide comprehensive understanding of the situation of TB epidemic and the response. There are different formats of reviewing TB program and implementation status of the responsibility designated to each department or sectors. First, People's Congress at national and local level conducted supervision and inspections of laws of infectious disease prevention and control, among which TB is a critical component. Second, National Health Commission, together with other departments concerned, conduct a periodic audit assessment of the progress of TB action plan. And third, the inter-minister joint meeting mechanism reviews the result and make decisions on further actions. This is the snapshot of the TB control and prevention strategy in China. As mentioned earlier, the roles and the responsibility of various ministers, departments, and sectors in TB response are clearly defined and documented in Health China Initiative 2030 and the National Action Plan on TB Control and Prevention, which involves many different departments, sectors, and NGOs, for example, finance, medical insurance, education, justice, security, State Council Poverty Alleviation Office, etc. Under the scope of designated responsibility, Ministry of Finance has been increasing investment for national TB program in the last 5 years, witnessed a 40% increase in TB fund at central level. National Healthcare Security Administration strengthened its implementation of responsibility in assuring the affordability of TB care and reducing financial burden experienced by TB patients, including through expanding health insurance coverage, introducing novel anti-TB drugs into benefit package, reducing price of drugs through various approaches such as centralized drug price negotiation, increase the reimbursement rates for TB care, and applying catastrophic health insurance scheme for MDR-TB treatment. Now, health insurance is lowering single disease payment for TB treatment to further reduce the financial burden of TB patients. Another example is the education ministry. TB prevention and control in school, which was led by education department, has been significantly stressed over the past year. From the slides, we can see TB screening rate has been increasing steadily among newly enrolled students. TB notification among students has been decreasing since 2018, and the number of TB outbreaks in schools decreased rapidly since 2018 as a result of the strengthened efforts in schools. Defining responsibility is not enough. Coordination and monitoring of the responsibility enforcement mechanism are critical. In China, multi-sectoral engagement is coordinated by the State Council Inter-Minister Joint Meeting Mechanism on the Prevention and Control of Major Disease, chaired by Madam Sun Chunnan, nearly Vice Premier of State Council. We can see in the meeting, Sun Chunnan recalled that all locality and departments should sincerely show their responsibility of prevention and control of major disease, improving their open mechanism, strengthen coordination of cooperation, and form synergy in the prevention and control effort. She also set clearly requirements in some concrete measures. Supervision and inspection of infectious disease law enforcement is a very important modality of program review, including for TB. In 2018, National People's Congress conducted a comprehensive review nationwide and identified a number of issues in TB response, including relatively limited level of medical treatment, cost guarantee for patients. The level of medical security is not enough. Patients out of pocket expense still beyond their ability to afford, which is one of the main reasons for the low rate of TB detection and rate treatment in China. This inspection also identified the gaps in TB prevention and control in school. Concrete recommendations have been proposed to address the issue and the challenges, followed by corrective actions taken by individual ministry and sector, including some person in charge, have been punished by the party and the government discipline. Madam Peng Liyuan, First Lady of China and WHO Goodwill Ambassador for TB and HIV, has been playing critical role and making outstanding contribution to the political advocacy and social mobilization for TB response, not only in China, but also internationally. The slide shows that almost every year, Madam Peng attended national and global TB events and called for whole society contribution in the fight against TB. To a large extent, her commitment and continuous engagement has set a role model and mobilized the multi-sectorial engagement and all society participation in TB response. Though there are a number of gaps and challenges existing in national TB response that needs to be addressed through intensified multi-sectorial mechanism, here list some, including lack of legal support and government investment for critical interventions. Over half of TB patients had catastrophic health in expenditure due to TB, and the level of medical security and social protection for TB patients needs to be improved. In addition, TB control among key population and specific settings, such as among migrants, minors, in labor-intensive factors and mining enterprise, closed setting, large-scale farms, needs meaningful engagement of ministries and departments and sectors. To ensure meaningful engagement, the responsibility needs to be defined more concrete and precisely with specific measurable indicators and target set and result-oriented performance reporting and evaluation mechanism developed. As shown in this slide, multi-sectoral engagement and participation will vary across the province and between the department and the sectors concerned. There are these areas needing urgent action in next national planning cycle for TB response, including for department to be engaged, the improvement in measuring indicators, the renewed performance evaluation mechanism, and accountability measures. Here are some sources of further strengthening China's TB response through multi-sectoral accountability mechanism, including focusing on the biggest gap and the most important challenge. In previous slides, there are many gaps, but we need to focus on the biggest gap and most important challenge. Clarifying and specifying the responsibility of relevant departments in TB response in the changing context. And the third one is to strengthen the role of the coordination body for TB. In doing so, the innovation and the lessons learned from COVID-19 response need to be considered and utilized. COVID-19 response in China really demonstrates the power and the effectiveness of a coherent and meaningful multi-sectoral accountability and whole society approach. In this process, WHO can play a significant role, including the engaging community living with and affected by TB. Thanks for the opportunity again, and thanks for your attention.
Thank you so much, Dr. Chen Zhongdan. I think that was an excellent presentation. Again, very comprehensive, giving a very clear step-by-step approach of what has been done and what has worked in China from the level of highest level leadership, thanks to the engagement of Her Excellency, the First Lady, to your State Council interministerial mechanism, and under the leadership of the Vice Premier, as well as it was interesting to hear about the inspection and the enforcement of the laws. You know, you gave the example of the schools and the education sector. So I think these are really great examples that other countries can learn from and replicate. So thank you very much for that, Dr. Chen. Over to you, Martin.
Thank you very much, Dr. Chen and Monica. And it is my pleasure to announce the next speaker, which is Dr. Linviwe Mvusi from the NTP program of South Africa. And Dr. Mvusi will present the experience of MAV-TB implementation in South Africa with the focus on the baseline assessment and the national MAV-TB rollout and development. Dr. Mvusi, over to you. The floor is yours. Thank you very much.
Okay, thank you very much, Chair, for the opportunity, and good morning, good afternoon, good evening to all the participants. Yes, just to indicate that we are still in the early stages in terms of the MAV. We haven't actually started the implementation, so my focus of this presentation will be on the steps that were followed to actually develop the MAV to the current stage. And just to also indicate that HIV is the main driver of tuberculosis in the country. We have a high TB incidence as well as high HIV prevalence, high death rates, high mortality amongst people living with HIV. But much as we have a high TB incidence, there is a reduction in the incidence, and this is mainly due to the scale up of the ART program. As a result, it made sense for us to actually look at the structure that actually is in existence for coordination of the HIV response in the country. We have the South African National AIDS Council, which initially coordinated HIV, AIDS, and STI response, and then subsequently included TB in the activities. And as part of that, the objectives of SANAC, mainly address issues around strategy and policy, providing governance, leadership, and management in terms of the response. And this is at the different levels of the system. So we have representation at national level, provincial level, district, as well as local level. And it also focuses on the strengthening the multi-sectoral response as a contribution to the overall socioeconomic development. And the other responsibilities, resource mobilization, especially to finance the gaps within the budgets available for our response, and then ensuring monitoring and evaluation of progress against the targets that have been set in the National Strategic Plan, as well as strengthening strategic information. I think the key role for the SANAC as well is strengthening the partnerships, especially inclusive of all the sectors, and there are about 18 sectors that are represented in SANAC, as well as other funders, including donors and technical agencies. In terms of, just briefly, there is a secretariat that is responsible for coordinating the work of SANAC. And at high level, it is a structure that is chaired by the deputy president. And we have an interministerial committee as well that's in existence. So we felt that this would be the best way of including TB rather than setting up a different structure for the MAF in the country. In terms of the representation, we have all the government departments represented, civil society, as well as the private sector. As I mentioned, there's about 18 in total. And TB had also been included within the activities of SANAC and in the National Strategic Plan for 2017 to 2022. And therefore, it was also felt that since there's already some of the other activities that are driven from the SANAC, which included the establishment of TB parliamentary caucuses across nationally as well as across provinces. And they were also responsible for the ambassadorial program. And recently, a TB Civil Society Forum has also been established. We, in our engagements, therefore, with the acting CEO at the time, there was acceptance of inclusion of the MAF within the sector. Particularly because this also would include this would include, the plan was that it would include HIV over time based on the lessons learned from the implementation of MAF TB. Obviously, this required mobilization of financial resources for the development of MEF, which was actually done thanks to the WHO country office, which assisted us with the funding for this. A person responsible for coordination of the TB activities within SANAC had already been appointed, which made it easier then for facilitation of the different sectors to participate in the development of this. We also had terms of reference that were developed for a structure that was going to coordinate the activities, which was the MAF TB reference group. This was established and it comprised of the NTP, SANAC Civil Society Forum, people living with HIV, and the private sector forum. We appointed a consultant to actually conduct the baseline assessment and develop the draft MAF TB for consultations. And this reference group met bi-weekly in the first 2 months, and then weekly to actually monitor the progress of the development of the MAF. And I must also acknowledge the technical support that we received from WHO HQ, regional and country offices in this work. With the desktop review, we basically looked at local data in terms of progress over time. We also reviewed the global and national TB commitments, which were made by the country. And we then used the WHO checklist and the questionnaires to conduct stakeholder interviews. We had agreed on a number of stakeholders that needed to be interviewed, but unfortunately, because we're conducting this during COVID, we were not able to actually interview all the people that we actually wanted to interview, because most of the interviews were conducted virtually, and we couldn't convene groups to actually do stakeholder engagements. In total, about 65 people from the different sectors, which included government departments, civil society, NGOs, donors, development agencies, private sector, affected communities, and people living with HIV and those affected by TB, as well as a few of our research institutions, those particularly that are doing a lot of work on TB research, and the TB ambassadors. And all the findings, therefore, from these consultations informed what would go into the draft document. The other point was that from the consultative processes, we had to then try and pull all the information that came through and probably pull out just the common trends across all the interviews that were conducted to actually inform what goes into the draft map. And again, we then had to incorporate the roadmap on how we can then strengthen the multisectoral involvement and accountability into the framework, based again on the inputs that came through. Subsequently, it became clear that we would need a technical working group, which would then be responsible for implementation and coordination within the SANEC structure. And this technical working group has been established already. And this brings together different stakeholders for the TB response to actually facilitate the work. And this structure will also report on agreed sector contributions, because all sectors would have to have their plans and the implementation plans, and report quarterly on the progress on this. And this would then be taken to the SANAC plenary, which is the high-level meeting which engages the key stakeholders on progress. As I indicated, some of the challenges that we had was that due to COVID restrictions, we were limited in terms of the number of consultations or workshops that we would have on the draft document. We then opted for circulating the document to the key stakeholders and then receiving their inputs and incorporating them in the document, which actually also took a bit of time. And lastly, we couldn't also reach all our stakeholders as we had planned during the interviews. And mainly, those were mainly the politicians, particularly the health minister, both at national level and in our provinces, and other government departments outside of health. And we felt that this was a huge limitation, but we were pressed for time and had to close the interviews. On the way forward, we now have the draft MAF-TB, and this needs to go through the processes for adoption within the SANEC structures and eventually to be presented at the interministerial committee and subsequently then signed off by the deputy president. And we are busy now developing the NSP for HIV, TB, and STIs for the period of 2023 to 2028. And the aim is that the MAF-TB will be embedded within the NSP, which will facilitate the mobilization of resources so that there's funding for its implementation, as well as accountability within the SANEC structures. So basically, our aim is that SANEC will take full responsibility for implementation, coordination, monitoring of the MAF-TB. And as the health department, we will, as all other sectors within the SANEC, will be responsible to account to the structure in terms of our progress. And that's all from my side. Thank you for listening.
Thank you very much, Dr. Lindiwe. Very impressive presentation, if I may say, and allow me also to indicate that I find it very effective and efficient. You did a very good mapping of existing stakeholders in your analysis and chose an existing strong one, the SANEC, to play a leading role. So this may be self-intuitive to some, but it is not trivial at all. It's always good and important the way you did it to see what is already existing as far as strong structures inside the country. And through linking the MAF or to having it vehicled and catalyzed by the SANEC, also at different levels, as you said, national down to local, you managing also to involve all those different stakeholders. Also, you're not being stopped by the COVID-19 challenges. You are overcoming them. This, of course, is or has slowed down all of us, definitely, but you're looking further ahead. And I find it also remarkable and excellent that you will be linking the MAF into the NSPs, and then also for TB and HIV and STIs. So this is actually a good example also how MAF functions as a vehicle or a catalyst for further systems integration here within the existing structures and diseases, and also for then resource mobilization. Thank you very much for this presentation. Very inspiring. Thank you. So without further ado, I would then be honored and pleased, very pleased to announce the last speaker of this session, Dr. Sayohat Hasanova, who represents the TB program, TB team of the WHO European Regional Office. The floor is yours, Dr. Hasanova. Thank you.
Thank you, dear Martin. Good afternoon, good morning, good evening, dear colleagues. It's my pleasure to present you the experience of the WHO European region in MAF-TB adaptation and implementation in the WHO European region, and also piloting of MAF-TB in 5 countries of Eastern Europe and Central Asia. Let me share my slides with you. And if you could tell me if you see the on your screen my slide.
Yes, we do. It's maybe not yet on full size.
Please. Okay, I will show you. Manufactured by Tumlangi, Tumia.
I think somebody is not. Yeah, I think you can go ahead now, Sayoha. Try again. Yes. You are muted, I think, still.
Yeah, thank you.
Now we can hear you.
I was muted. Yeah, my presentation is focused mainly on the process of adaptation implementation of MAF-TB in countries of Eastern Europe and Central Asia, in 5 pilot countries. So to start,
Sayohat, sorry, can you go on slideshow, please?
Monica, with the slideshow, I'm having some challenges. That's why I tried to put it like this. Can you see it?
No, no, we can't see. So maybe if you can stop sharing, E will share it from here. Okay?
Yeah.
Yeah.
Yeah, thank you. Next slide, please. So we start the operationalization of MAF-TB in our region in 2020. And we conducted a consultation with the main global and regional partners on MAF-TB adaptation and use in WHO European region using conversational interview approach. And the main objective of this conversational interview was to gather subjective information to ensure the co-generation of knowledge, to ensure the co-create a vision for the operationalization of MAF-TB at the regional and country level, and to ensure the sustainability of MAF-TB implementation. So the result of the interview were analyzed and documented. In parallel, to support and guide countries, in collaboration with the Global TB Program, we developed a regional concept where we suggested action points and tools on how to adapt and to launch national MAF-TB at country level. And these tools we've been piloting in 5 countries of Eastern Europe and Central Asia in close collaboration with TB Europe Coalition. And those countries are Republic of Moldova, Republic of Belarus, Kazakhstan, Ukraine, and Tajikistan. We've also supported countries in adaptation of MAF-TB baseline assessment, checklist, and its annexes, including using supplementary tools for data collection, data analysis, and the consolidation of the baseline assessment results with recommendation, which further serve as a source of evidence-based information for the development of national MAF-TB roadmaps. The technical support also included strategic advice and the technical support and development of national roadmaps, which is tailored to the country context on strengthening multi-sectoral collaboration, coordination, and accountability. We also provided strategic advice in setting composition and roles and responsibilities of national multi-sectoral coordination bodies and high-level review mechanism, and also on addressing MAF-TB in the national strategic plans on TB and funding application of external donors. Next slide, please. We also developed MAF-TB web page. Here you can see our web page in the WHO Europe Public TB website. And we put in all information related to TB, and this webpage will be regularly updated. And you can see in the bottom of the slide the link to this webpage. Next slide, please. One of the, and also MAF-TB was one of the priority themes in World TB Day 2021. And for that, we've developed a statement in support of MAF-TB implementation at country level, which was used by WHO representatives and WHO head of offices for their press conferences and advocacy meetings. Next slide, please. And coming back to the action points we suggested in the regional concept document for pilot countries and which needed to have in place at country level to initiate and launch MAF-TB includes conducting national multi-sectoral and multi-stakeholder consultation to initiate MAF-TB. This also includes appointment of national MAF-TB focal points to coordinate all processes related to the initiation, adaptation, and launch of MAF-TB. The next action point, suggested action point, was conducting MAF-TB baseline assessment to evaluate the baseline situation with multi-sectoral TB response and to generate the evidence across all four MAF-TB essential components and elements. The next action point was the development of national MAF-TB roadmaps, which should include vision and approaches on how to strengthen national multi-sectoral framework, how to engage all sectors in TB response, and how to increase all stakeholders' accountability. And the next action point, suggested action point for country, for pilot country, was formalization, or if already existing, strengthening multi-sectoral coordination body and review mechanisms. Next slide, please. One of the important enablers of MAF-TB a successful implementation is participatory approach, which creates a joint vision, which contributes to capacity building and empowerment of all stakeholders, and which ensures the country ownership. So at country level, partners in pilot countries, partners in MAF-TB adaptation and implementation included Ministry of Health, national TB programs, other relevant ministries and bodies, civil society and affected communities, parliamentarians, secretariats of country coordination mechanism, technical agencies and donors and national experts. We've been partnering with TB Europe Coalition to actively engage national civil society and affected communities in all MAF-TB related processes at country level. And this partnership in particular included the implementation of Annex 2 of the MAF-TB baseline assessment checklist, using the auxiliary approach to the data collection, and also it includes development of guiding documents for civil society and TB affected communities on the use of MAF-TB. In partnership with TB Global TB Caucus, the checklist has been developed and piloted in Ukraine on assessing the engagement of parliamentarians in national TB response. Next slide, please. So piloting is still ongoing, and as Martin mentioned, of course, COVID and the humanitarian crisis in Ukraine a little bit slowed down the implementation. However, it's ongoing. And the countries are at a different stage of adaptation and implementation of MAF-TB. All 5 countries, as you see in this slide, they pointed their national focal points. They conducted already national consultation to launch MAF-TB, and they conducted baseline assessment. And countries are at a different stage of developing national MAF-TB roadmap. Some countries already developed and endorsed, such as Ukraine, but other countries in progress, such as Republic of Belarus and Moldova, and Kazakhstan and Tajikistan, they have planned developing the MAF-TB roadmap in their national strategic plans. So multi-sectoral coordination body, as the result of baseline assessment has showed, existing in all countries, but unfortunately it needs to be strengthened in order to meet the all MAF-TB principles and requirements. And as assessment showed, high-level review mechanism is not in place in countries. However, all countries that they put in their MSP plan to develop this mechanism. Next slide, please. And piloting has shown some lessons which need to be considered, and here we can see some of them. Firstly, as I mentioned, participatory approach is important in MAF-TB adaptation and launch. And in pilot countries, we use this participatory approach, which enables country ownership. It helps to build capacity of involved stakeholders and foster collaboration. In addition, appointment of MAF-TB focal points in these countries helped in coordination of activities related to launch of MAF-TB, including conducting baseline assessment. And the involvement of civil society and affected communities and members of parliament from the early stage of MAF-TB implementation catalyzed and fostered multi-sectoral collaboration. Secondly, conducting baseline assessment is critical, as we mentioned today, to generate evidence across all 4 TB essential components, and adaptation of MAF-TB baseline assessment checklist and using auxiliary tools for data collection in pilot countries added value for data analysis, data validation and triangulation, and development of sector-specific recommendation. Thirdly, it's vital to ensure sustainability of MAF-TB and the alignment of MAF-TB with the national strategic plans. As Martin said, it's important to ensure MAF-TB sustainability. And in addition, continued technical support and capacity development is needed, which contributes to MAF-TB sustainable implementation. That was my last slide. And if you go to the last slide, using this opportunity, I would like to acknowledge all those colleagues and partners who were involved in adaptation and implementation MAF-TB in our region and in piloting MAF-TB. You can see here the list. And thank you very much for your attention. Over to you, Martin.
Thank you very much, Sayohat, for a very comprehensive and clear presentation, if I may say, and very good that you managed to have such a strong support from the regional office level also, and your contribution to supporting the countries in collaboration, of course, and as led by WHO headquarters and with the partners and also colleagues, partners, and WHO on the ground. The piloting in those 5 countries I see has helped you a lot. And also I see you've chosen a very thorough and inclusive approach in getting to the goal and the target through consultation, the baseline assessments, the roadmap development, and now the formalization of it. And also no need here again to reinvent the wheel. It can be an existing strong suitable body, or of course, if not existing, then also something new. Very participatory approach. And also you also highlighted the approach to sustainability through the linkages of building into national strategic plans. And here also in the lessons learned, we see that flexibility is key and that some adaptation may be needed throughout the process. Thank you so much for this. Without further ado, and now having had these 4 presentations for our inspiring or to inform and inspire our discussions, I give the floor back to Monica. I understand she and her team have been monitoring a lot of questions that came throughout the sessions, and now is the time that we can address some of those. Monica, back over to you. Thank you.
Thank you, Martin, for co-chairing the session and for moderating all the presentations. Much appreciated. So, and many thanks to all the attendees and participants who've been posting questions. We've received over 26 questions from you all, and we're most appreciative. We'll try and take a few questions live. We are a bit over time, but we'll take 10 minutes to do a bit of Q&A as promised. We'll try to keep it as interactive as possible. And we'll, so let's just go with a few of these questions first. So let me start from the Q&A chat. I see Ganesh Acharya, you've posted a couple of questions, but basically you've been talking about the importance of health equity, the various social drivers of the epidemic, poverty, and that there is need for looking at, addressing efforts to end TB beyond just medicalizing it. And you've asked questions about, a framework on community engagement and other support elements. So for this, I'd like to perhaps give the floor to someone from WHO to maybe respond to you first. We have with us here Dr. Farai Mavunga. He heads the unit on vulnerable communities, comorbidities, and on civil society engagement. So Farai, we'd appreciate you giving a response to this question from Ganesh.
Okay, thank you so much, Ganesh, for those comments. Yes, just to acknowledge that the areas that you've highlighted are also a priority for WHO as well. So within the department, there are various streams of work where we are trying to really address these factors in addition to our technical guidelines. So I think as many of the colleagues online would know, we are updating the guidance for national strategic planning for TB. I think many of you have provided inputs, and we're in the process of finalizing that document for printing and publication. And the main reason why I'm highlighting it now is that one of the things that we really encourage in this guidance is an inclusive process of national strategic planning that responds and addresses to the needs of the communities, the affected people, as well as quality people-centered services. So that's one of the key principles that we are promoting in this guidance. And we believe that this can be achieved by ensuring that the right people are engaged and involved in the planning process, and are also capacitated to be able to meaningfully participate in these activities. Similarly, some of you would have participated in the guidance, the consultations that we had on the guidance for social protection. Again, this is an area that we are trying to make sure that we integrate it into TB services. And so we are really looking again beyond just providing treatment. We are looking at comprehensive services for people with TB. We have started other initiatives to address TB in vulnerable populations. I think a number of speakers have highlighted that TB is indeed a disease of the marginalized. So one of the recent publications that was released by WHO in collaboration with other agencies is the Interagency Field Guide, a manual for addressing TB in refugee situations. So we will also be doing a bit more work on other vulnerable populations. And I think we expect to be engaging a lot of you in the discussions going forward. And similarly, many of you would have been involved in implementing the Engage TB approach, which is an effort to engage civil society to address TB. Again, we are updating that guidance, that Engage TB approach, to really embed, again, the communities within the TB response. But I think that all these aspects, I think they do highlight the importance of this session that we are having today, that all the relevant sectors to address the needs of the vulnerable populations would need to be engaged, because I think a lot of it is beyond TB programs. A lot of it requires involvement of other sectors. So I think those are just the highlights in terms of some of the ongoing work to try and address some of those. But we will continue to engage with you in the discussions to get your input, to get your advice on how we can best do this. Thank you.
Thank you so much for that comprehensive response, Farai. And Ganesh, we welcome you to also reach out to us. And, for more information, our website has all of these resources available, and we regularly have webinars on all of these various topics. We also have several other questions that have been directed to panelists. So let's go now to a question that was directed to Dr. Ethel Maciel from Felix Mboya. Ethel, there's a question. I see you've responded online, but we'd like to also take it live about the need for strengthening TB-HIV collaboration in HIV clinics, the need to encourage decentralization to reduce loss to follow-up, lack of transportation, and what the challenges have been and how to overcome this. Over to you, Ethel.
Thank you, Monica. So it's a very complicated subject right now, as I told to Felix that make the question. We have in Brazil, they are as a two separate service. One is the HIV service, and other HIV program and tuberculosis program. And they work as they are a completely different program. They have completely different structure, and they integrate between them. It's very few. Only in the last 3 years, they are work more together. But when the patient has they need to go to the HIV clinic to see their physician, and they need to go to the TB clinic to see the health professional in the TB clinic. They don't share knowledge and everything, all the patient. It's two different service. And unfortunately, I don't see this change in a short period of time, because right now we have a very complicated political situation in Brazil. Is a presidential electoral year, so I think we need the political will to change this, and right now we don't have this. So as I'm not talking for the NTP program. I'm a research. I'm talk for as a research consulting for the NTP, but it's a very complicated time. So Monica, unfortunately, we don't have like an answer that we need to do this to change this. We need the political will, and it's a difficult time to have this right now in Brazil.
Indeed, Ethel. No, completely agree with you. We can see that collaboration within the health sector is complicated, and that also leads to, of course, there are complications when you look beyond the health sector as well, and this is why the need so much for political leadership is so important. To have buy-in, commitment right from the top all the way down to enable this sort of collaboration. And I see that others, Mabel has also made, no, not Mabel, Dorothy Adongo has also spoken about issues like, national elections, changing governments, all of these. It's true, these are real situations on the ground that can challenge, what's happening right now. Okay, so let's go to another question very quickly. We have time for just 2 more questions, so I'll go to this one to Dr. Chen, who's also responded online. But there are 2, I'll merge these 2 questions in. Dr. Chen, maybe you could Dr. Chen Jongdan, maybe you could very quickly speak about this request for the need of more CSO, civil society and community organization engagement, this need to scale that up, and also on, research, financing and capacity building. There are 2 questions that have come to you in the chat. Thanks to those who've raised this. Over to you, Dr. Chen.
Very much for this questions. Very critical. Regarding the research, I mentioned the suboptimal use of research funding, because there are various sources of funding for research in China, including from government, in terms of Ministry of Health, in terms of Ministry of Science and Technology, different sources, and also private sector, international organization. But this funding use is not very well coordinated. So some research repeatedly conducted. And in addition to the capacity, in using the standard approach for research is a problem. So resulting usually the result are not able to inform the guidance development, are not used to inform including the international guidance and the national guidance. So this is a significant issue regarding coordination and also the quality capacity of the research. Regarding the CSO participation, indeed, that's CSO engagement for TB is at a very early stage, only limited participation, especially from community affected or even with TB community. There's some engagement of TB patients in the service delivery, especially for counseling, education, follow-up for MDR TB patients in previously in areas with previously have a lot of international funded project. But now government really realized that this patient support needs to be strengthened. So they are working on that to mobilize TB patients in the TB response now, and working on the play, and also the mobilization of the communities. In addition, the HIV areas could provide more experience, because in HIV response in China, government really dedicate funding for CSO, CBO engagement. So this is a very good example for TB to follow. So I mentioned in last night for WHO China office, this is a very important area for us to facilitate and for advocacy. Thank you.
Thank you very much, Dr. Chen Zhengdan. Much appreciated. And thank you to Zaidul Islam and to Felix Mboya for those questions. Now we have time for one last question before we close this session. Actually, it's a kind of a question that's resonating through several of the participants. Thank you, Sabah, who is a young TB survivor and TB champion from India, for your question. She's asked a question about the need for resources to, on the ground, and the challenges around this. This same question has been also expressed by Ferdiana Unita, who speaks about the issue in Indonesia, and also about finding resources and budget for engagement across sectors. Willy Zungundi as well has also spoken about the lack of resources, especially for survivors and their families. So a lot of questions around the need for resource mobilization, for funding, and also for it to reach across all levels. For this response, as well as to respond to several other questions, I'd like to turn to our director, Dr. Teresa Kasaeva. Over to you, Teresa.
Yes, dear colleagues, friends, I'm really following your questions with a huge interest, and thank you very much for active participation in this discussion. It's extremely important not only to share information from our side, but also to receive your comments and feedback. It will also guide us what we can do better and more, and how to address better the issues. I would love to respond maybe to many of your questions in more details, and probably we are thinking now to have organize another meeting purely with questions and answers, and probably we will ask you to share with us these questions in advance, but it's for future. But now it's one of the fundamental questions: how to attract financing to fill our chronic gaps for TB. The answer is not easy. The situation is complex, but it's possible, because we can see it clearly from some good examples and practices. First of all, we should start from the communication, how we are presenting TB case. And despite of all the challenges that are clear, that are in place, that TB was unfortunately deprioritized and neglected for many years, we should stop presenting TB as a failure. We should present TB as an opportunity, as a really model, especially learning lessons from the COVID-19, when TB programs heavily contributed into the COVID response, and it clearly shows that these previous investments were extremely impactful, and if we would like and the world would like to strengthen preparedness and response to the pandemic, TB programs are right programs to continue investing in. And we can also present TB, given its nature of social the risk factors and determinants depending disease, like an example and experience which could be expanded with this multi-sectoral approach to other sectors. Let's try to use this option. And when you're asking where from these resources should come, first we should advocate for increase in the domestic resources. Even if the domestic budget are tiny, any increase, even some increase, just to see this movement will be appreciated. Then international donor funding, again, here we should present clear needs beyond health-specific needs, like social support, which is absolutely essential. And we can see here concrete examples of how side effects are affecting, how out-of-pocket expenditures didn't allow to cover some family needs. And all these are clear examples of obstacles, and we should bring it to attention of our traditional donors to make these non-traditional investments in other areas beyond just drugs procurement and access to the diagnostics, which are also extremely important. Then we can Another way could be with the meaningful engagement of different sectors and embedding some specific activities into their portfolios with the funding from their budget. For example, we have in many countries programs for social support of some vulnerable categories of populations. And if you look and check if TB patients, at least children or any other TB patients, vulnerable groups are involved in these social protection programs, you will find that even in the high TB burden countries, they're frequently not mentioned at all. And there are some specific budget for these categories, and we should do our best to provide this inclusion, and then funding probably will start coming from the sectors beyond health sector. Also, let's try to be opportunistic and proactively look at other opportunities, how to attract domestic funding beyond traditional health sector and our traditional activities. There are many questions about community and civil society role, and I support with both hands. This role is absolutely crucial and critical, and we should provide meaningful engagement, and not only engagement, but also we should financially support these activities. The only one way is to identify these clear activities jointly, this specific role for this community and civil society groups, and agree on holding ourselves also accountable for these activities. If we are bringing these proposals, here are clear activities, and we are committing, if we will be provided support to reach these targets, some groups provide social protection, then it's a very solid basis for the dialogue, for the negotiations. And we will be happy from our side also support. We're trying to promote it also through our guidelines, new tools, where we're strengthening and highlighting in a different manner than neither we've done before, role of civil society and communities. So on the uptake of our guidelines, I see colleagues are responding. Also, we understand that this is a real bottleneck, because it takes years to use much better treatment and diagnostics options. So that's why we've tried to start from ourselves and significantly shortened all the process from prioritization of some research activities till the release of the guidelines. Guidelines now are coming in consolidated manner together with operational handbook, and beginning from this year also accompanied by training courses. All the tools are available through TB knowledge sharing platform in the digital format. So we are trying to do our best to make this uptake faster, but of course we will need also your support, and please share your vision ideas how we can do better. So, and final point from me, how to address these out-of-pocket expenditures. Now we are looking forward to the high-level meeting, and yes, we've been proud of having very strong commitments and targets, but probably we should go beyond this time. We should even strengthen our requests to the member states and concretize our commitments and targets even better, including those on catastrophic costs. I've seen there have been questions, so what should be the best approach? Either we should have more reasonable targets, less ambitious, and then they will be easier to achieve. Of course, it's my personal opinion, but we should not step back from our targets. More modest we are, less we will receive. So that's why let's continue moving with this intention, and thank you once again. Let's continue.
Thank you very much, Teresa. And yeah, thanks so much for all the questions. Please keep it coming. We have another session next where you'll hear from partners, but these are important questions, and our panelists from this session will continue to respond to any burning questions that you may have. We'll respond online. But there is still the opportunity for much more. So I'd like to thank the participants as well as the panelists. I'll turn over now to Martin to close this session before we move to the next.
Thank you very much, dear Teresa, dear Monica, dear colleagues. It's my pleasure and honor to briefly close this session. And I would like to very briefly bridge onto what Teresa said. We actually see, or we saw also throughout the 4 presentations given from South Africa, China, Brazil, and the WHO European region, that TB has been a very strong contributing factor to health system strengthening, not just within the COVID-19 pandemic, but also before, and it will also go beyond that. And we saw several examples, many of them leading to joint and synergized policymaking at country levels, be it through national strategic plans and also others. And I also do see a lot that in examples, and many of those presented, if not all, had those where we produce results, for instance, through catastrophic surveys, cost surveys, where we see that actually indicators improve, as in China, and where we have very top-level leadership, like in China, and also where we use existing mechanisms, such as in South Africa through the SANAC, and where we have good linkages and full inclusion and transparency, such as was showcased by our European colleagues. We can showcase and demonstrate success, and then funding and further resources and also sustainability will follow. I thank you very much for this honor to co-chair. We will be also applying the gained knowledge in our region here, and I give the floor back to Monica and colleagues. Thank you very much from Cairo. Thank you.
Thank you very much for that, Martin. Appreciate your co-chairing of this session. And thank you again to the panelists and the participants. Please stay on. We have a very comprehensive session today. So we are now moving from the country to a multi-stakeholder panel. We have, as I said at the start, we have 4 partners with us. From UN agencies, we have the International Organization of Migration, we have International Labour Organization, we have our partner, the Stop TB Partnership, and of course, from civil society, we have the Civil Society, WHO Civil Society Task Force. This is going to be more of a Q&A style session, and So let's begin with this one. And again, I'd like to remind you of two things. One is we plan to have another Q&A, live Q&A session towards the close. So if you have questions, please put them on the using the Q&A function. And the other point is we're going to have a voting at the end of key priorities needed for the operationalization of multi-sectoral accountability framework and action, the operationalization of all of that. So just keep in mind that my colleagues will again put the Slido link on the chat where you can post your suggestions. So without further ado, I'd like to turn to the first speaker of the session. We're very pleased to have with us Dr. Chris Gilpin. He is the Global Lab Coordinator at the Migration Health Division in the International Organization for Migration. Thank you for joining us today, Chris. We'd like to hear from you. It would be great if you could share IOM's work on TB and migration and your upcoming plans for increased resettlement of migrants and refugees for 2022 in this whole context of multi-sectoral engagement, action, and accountability. So over to you, Chris.
Okay, thank you, Monica. Thank you, Teresa, for the invitation and opportunity to present on IOM's work, particularly around our multi-sectoral and interagency agreement to end TB among migrants and refugees. And it's a privilege to move away from policy development to actually working with implementation of the WHO guidelines and best practices to address the health of migrants and refugees. So briefly, the way I'd like to address your question is using this short presentation and firstly begin by getting everybody on the same page about what are the complexities of migration and standardize the terminology that we use. I'd like to describe our IOM health assessment activities and the global footprint and presence we have, along with our services and capacity, largely focused on addressing TB amongst the migrants and refugees. And I'd also like to just present some different examples of interagency collaboration to end TB, one with FIND, one with Global Fund, and another with a national NTP. But this is in addition to the ongoing technical collaboration IOM and WHO have with the developments of guidance around diagnostics, radiology, etc. So firstly, if we look at the complexity of migrant flows, if we start off in the bottom right in the country of origin, now it could be through conflict, through some sort of natural or environmental disaster, people get displaced and have to move away from their homes, their regular place of living, and they can remain in their own country as internally displaced persons. They may move to a neighboring country or another country and declare themselves as refugees or seek asylum in that second host country. They may remain in that host country for months to many years, where they could later be integrated into the host country or be returned and reintegrated into their country of origin through repatriation. Or alternatively, the refugees and asylum seekers could be resettled to a third country or may choose to immigrate from their country of origin to that third country. And at every step of the way in this migration process, the migrants can have increased vulnerabilities to TB, may have lack of access to health services. And so at each step of this migration process is an opportunity to address the health of the migrants and try and reduce TB as a problem amongst those migrants. So what IOM does is conduct health assessments pre-departure. So where we have the opportunity to have migrants or refugees resettled, the aim is to conduct a health assessment within the country where the migrants are, and to screen them for a range of conditions, of which tuberculosis is a key condition. Many of the migrants are moving from countries that have higher rates of TB to destination countries with relatively low rates of TB, and hence addressing the TB amongst the migrants in their country of pre-departure provides benefits to the individual migrants and refugees, allowing them to be diagnosed and effectively treated. It can then contribute to reducing the incidence of TB in the host community through early detection and initiation of treatment. But this pre-departure screening also contributes to lowering the incidence of TB in the destination country. So you're not having prevalent cases of TB traveling and then either developing more active forms of TB upon arrival. And this pre-departure screening and detection of active TB and TB infection amongst children is a key assessment for a key activity for the health assessment program. So this is not done in isolation. It does require close collaboration and engagement with the NTPs, as well as our member states and partner governments who are going to be receiving these migrants and refugees. So all of those dots there represent the locations where we have migration health assessment centres. And currently, as of 2022, we have 69 health assessment centres in 49 countries. So, but not all of our migration health assessment centres have laboratories or have the full capacity to perform all the tests that need to be performed to assess the health of the migrants before departure. What we do have is partner laboratories that IOM engages with, particularly in settings where the caseload of migrants is small or other facilities are already existing that don't need to be duplicated by IOM. An example is in Europe, where there is a well-developed health systems. IOM does not establish its own facilities, but partners with our different partners for provision of laboratory and other diagnostic services. We do actually operate 10 TB laboratories, TB culture and DST laboratories across Africa and Asia, and 34 laboratories that perform serological tests as well as other tests using GeneXpert, either for TB, for sexually transmitted infections, and of course, more recently for COVID. Now, in order to screen for tuberculosis, we require radiology as the initial entry point. And so all adolescents 15 years and older and adolescents and adults undergo chest X-ray screening. And then those with abnormalities on chest X-ray consistent with TB submit sputum samples that go for culture and DST if they're culture positive. But in order to ensure that we have good quality radiological services, we have 2 hubs of teleradiology centres in Manila and Nairobi that provide the oversight and quality assurance for radiology. So this is the first project, our interagency collaboration I wanted to present to you. And it's a collaboration with FIND, and it's focused on TB and COVID co-infection. And since both diseases have similar presentations, although there's many differences, this was conceived as an opportunity to perform COVID testing amongst persons presenting at TB clinics for a diagnosis of TB. And so this initiative has been established in a number of sites in the Middle East. And another project using the rapid antigen test for COVID has been antigen RDT self-tests being distributed to Ukrainian refugees at border crossing and shelters in Moldova, along with a communication package to access health services. So this could be for COVID-related or for TB-related symptoms. And so it's an opportunity to intervene with the health of the migrants during their migration pathway, and also an opportunity to evaluate them for TB as well as COVID. And this on the side here is just an information package that's been translated into Ukrainian that can be handed out to those who may benefit from performing a self-test and empowering them with knowledge whether they have COVID or may be infected with TB or other respiratory illness. Another collaboration is with the Global Fund in a number of Middle Eastern countries. And these countries have protracted conflicts that have caused region-wide population displacement, coupled with health infrastructure and health system destruction. So these countries, we know them all, Yemen, Syria, Lebanon, Jordan, and Iraq. Although we have the national TB programs as the lead partner, in order to coordinate the activities focused on TB in these countries, IOM has received Global Fund grants and is the principal recipient of a fund where we have technical regional coordination with WHO, with UNAIDS, as well as the NTPs, to actually coordinate not only the diagnosis, but treatment of TB. And you can see, since this initiative began in 2017, numbers of TB cases being detected has increased to almost 20,000 during the project, even despite much of services being disrupted due to the recent pandemic. And these countries also host a large number of migrant populations that pose challenges to control and elimination of TB within these countries and in neighbouring countries hosting the displaced. And then the final example I wanted to present of is an example of IOM's migration health presence in Afghanistan, where there is a large population of internally displaced persons that have a range of health vulnerabilities. So IOM has health programming in 12 of the provinces bordering the neighbouring countries of Pakistan, Iran, Central Asian countries. And in 4 of these provinces also provides TB services, both diagnostic and treatment services. So this is just a few examples I wanted to share. At the bottom there, you see we have a range of partners, again, who are working with IOM to address the health of internally displaced persons within a conflict-affected country, but still maintaining a focus on general migration health, but looking at mechanisms to address the burden of TB at the same time. So I will stop there, but thank you for your attention.
Thank you so much, Chris. Very comprehensive presentation with great examples from countries, collaboration with partners like WHO, Global Fund, FIND. All of this, of course, essential when you're looking at supporting and helping address infectious diseases like TB among migrants. So very much appreciated. We'd like to ask participants if they have any clarificatory questions to please post them on the Q&A. So thank you, Chris. Without further ado, I'd now like to move to the next presentation. We're very pleased to have with us, just give me a second. Yeah, Didi Shah from the International Labour Organization. Hi, Didi. Didi is the technical officer for the Gender Equality, Diversity and Inclusion branch at the ILO. Her main area of work is HIV, but she's also involved in work around key populations for HIV, which of course includes people with TB and indigenous peoples, and she has over 2 decades of experience in this area and has worked closely with WHO and UNPF. So let me turn over to you back again. Didi, we'd be very appreciative if you could share with us the work that ILO is doing especially on social protection, workplace engagement linked to ending TB. So over to you, Didi.
Thank you very much, Monica. I would like to share my screen. I hope you can see it now. Just to give a short presentation, thank you very much for the invitation to this very important event. I've been following throughout the whole afternoon, here it's afternoon, and it's very interesting. So thank you very much for the invite. So I would like to give a few examples of ILO's work on TB. At the international as well as the national level. Just a brief overview. I would like to start with some of the important conventions we have at the ILO that really frame our work in this area. So the ILO Convention on Discrimination, Employment and Occupation is from 1958. It's a very old convention, but it's still very valid, and it's one of the most ratified conventions in the world. It's very useful because it's very broad. It defines, for example, discrimination as any distinction, exclusion, or preference. So what we focus on in our work, if we, for example, implement diagnosis for TB or HIV in the workplace, we need to make sure there's access to treatment, which is mainly through public health services, so in collaboration with the Ministry of Health. And we also need to make sure that human rights are respected. So people cannot lose their jobs because of TB diagnosis or because of TB treatment. TB should not be the reason for termination of employment. So these factors are very important. Some of the other tools we have to guide our work on TB is joint guidelines, WHO, ILO, and UNAIDS. We have a step-by-step approach on integrating TB into HIV workplace programs, and a very important recommendation 200 of the ILO is focusing on HIV and AIDS in the world of work, but it has proven to be very relevant also for TB in the workplace. It speaks about confidentiality of medical data, of the diagnosis, and protection of job security and non-discrimination. We also have recent guidelines on integrated health testing approach, which we implement in a focusing on health and wellness approach in the workplace, where we have seen that the benefits are that people who are afraid to get stigmatized or discriminated because of accessing TB diagnosis or HIV testing if you implement this in a broader approach, the stigma is really reduced, and people are more accessing more the TB and HIV testing diagnosis. So some recent studies we also did on TB and HIV is a qualitative study on this stigma discrimination experienced by indigenous peoples living with HIV or having TB. That really revealed like multiple layers of discrimination that people, indigenous people with TB face. Because they're indigenous, because they have TB, and sometimes even because they are part of LGBTI community, or sometimes because they're female. So that study really revealed all those different layers of discrimination. A recent study, Making Universal Social Protection a Reality for People Living with, at risk of, and affected by HIV or tuberculosis was like a review study of what is there and giving some recommendations, like some of the recommendations that came out that better documentation is needed. So the good practices are better systematized. So they help develop guidelines and mainstream HIV and TB within existing social protection tools and mechanisms. Also one of the recommendations is that active efforts to ensure integration of TB and HIV should be integrated in a wider social protection program and schemes. Instead of focusing on disease-specific programs that is causing mainly more stigmatization. So we advocate for a wider approach. So also the critical importance of social protection institutions is partnering with organizations that provide prevention and referral services. So this is really speaking about a more integrated approach and more coordination. And also we have seen that the COVID-19 pandemic has enhanced the shock responsiveness of social protection systems. And we think that further research on this and on the latest implementation of social protection systems around COVID-19 might be very useful to identify more policy lessons on social protection. So our work, I will focus now on last year on the work we coordinated with WHO. The ILO, I mean now the Social Protection Department and the Gender Equality, Diversity and Inclusion branch. In this last branch I am working. We supported the development of the WHO guide on TB and social protection, which is forthcoming. By authoring a chapter on protecting employment and income of people with TB, and also by providing input on the chapter on ethics, where we made a lot of use of recommendation 200, which I mentioned before. We also provided 2 case studies for this guide, and one of the case studies on Kenya also featured in the NTB summit in 2021. On the other side, WHO was also on the panel for the launch of the study I just mentioned on making universal social protection a reality. So we have a very good mutual collaboration. I would now like to mention a few examples of workplace engagement. This is an example from India of an ongoing program where the main focus is on strengthening collaboration between Ministry of Health, Ministry of Labor and Employment, and employers and workers' organizations. So it's a very important collaboration because all of these partners are key in making this all work. So what was done was a policy framework was developed. There's also good practices of companies and enterprises are documented. There is a training manual. A study is now being undertaken to analyze the impact of TB and MDR-TB on workers in the formal and informal sector. And this is, I think, very interesting. There's a statement of commitment of Indian employers organizations. And they mention, among others, confidentiality of diagnosis in the workplace of TB, and no discrimination or stigmatization of employees on the basis of TB and on real or perceived HIV status. And also, TB and HIV infection should not be the cause for termination of employment. So this is like very much based on the recommendation 200 that I mentioned before. So this is a quote from a person with TB who says, "I could beat TB because I had job security. The support of the employer has a big impact. In BEST, that's the company she works for, benefits like paid leave, free medication and hospitalization, and thoughtful colleagues bring great comfort." So she was able to overcome TB and overcome the treatment because of this commitment of the company she's working for. So BEST is company in India on working on electric supply and transport, and it's a long-standing partner of the ILO. Then I would like to go to an example on workplace response in Kenya. So the context was that 40% of people with TB were not diagnosed, and those were mainly men in the productive age. TB treatment is free of charge, but and available at public health health services. However, 27% of households faced catastrophic costs. And this proportion was even 3 times higher for those affected by drug-resistant TB. So direct non-medical costs, for example, expenses on food and nutritional supplements, were the largest of those cost drivers, followed by productivity losses of people who could not work. And over 60% of DRTB patients lost their job due to their disease. So what was done? The ILO has a program that's called VCT at Work, where we offer voluntary counseling and testing for HIV, in this case, at the workplace. That includes a workplace policy protecting rights of workers, for example. And it also implements counseling and testing in the workplace. In Kenya, this model includes TB response, social protection, and health and well-being. And it was implemented in the formal and informal economy to actively find cases of TB. Also, the National Health Insurance Fund and the National Social Security Fund in Kenya were collaborating with this project. They sensitized workers on the process of the importance of registering for Social Security benefits and enrolling in the schemes. They found out that workers were not really informed about the benefits, and also they struggled with enrollment. So on-site registration was facilitated, and also payments through mobile money transfer really made it possible for people to enroll in that moment in the workplace. So a lot of other things are done in Kenya. I just included this slide, but I will not go into the details. But maybe important to mention would be that cash transfer programs utilize a harmonized tool that includes chronic illnesses such as TB as part of their selection criteria. This is my last example. It's an example of a whole sector coming together in the response to HIV and TB. It's the Masoyi's health program in South Africa, where mining companies come together and committed to a health program. So in 2018, a total of 32 companies representing over 370,000 employees reported their results. The percentage of employees counseled for HIV improved from 8 to 84% in 2018. and the screening for TB was 90%. Over 3,000 TB cases were diagnosed within this program in 2018. One of their goals was to have the TB incidence, which was historically higher in mining companies, to have that lower than the South African national incidence. And they reached that goal, except for the gold mining sector. But in general, it was reached for the whole mining sector. Here we can also see a statement from the employers. So healthy workers are productive and raise healthy families. So healthy and informed workers are key in ensuring healthy communities. So this is a part of a commitment of a whole sector working on HIV and TB response. So companies are interested in early detection because it means they can keep productivity at a high level, and also they can keep skilled workers. So in summary, what can the world of work do for a multi-sectoral response in TB is engaging with the Ministry of Labor, employers and trade unions, in addition to the Ministry of Health. Also to contribute to early detection and treatment by using existing workplace structures, support treatment adherence through employers' policy, so making sure people will not get laid off because of illness. Also, treatment adherence can be supported by a lot of big companies, sometimes have their own health facilities, so that can support treatment adherence as well. And to contribute to protecting the rights and ending discrimination. Also expanding the reach through corporate social responsibility efforts that companies implement is a good way to work on TB. Thank you very much.
Thank you so much, Didi. Excellent presentation, very comprehensive, all the way from the work you're doing on social protection to workplace engagement. Indeed, we've had a history of collaboration on both of these topics, and there are new social protection guidelines that will be coming out soon in collaboration. And thank you for showcasing the examples of India, Kenya, and South Africa. I think that really gives us a very clear picture, and it also addresses some of the questions that are coming up on the chat about engagement, about job discrimination. Indeed, the world of work is super critical, given that half the world's population is in the world of work, and it can also be one of the best ways to reach people with care if we do work closely with workplaces. So thank you, Didi. Please do look at the Q&A, and we'd appreciate, we'll come back to a Q&A session, but we'd appreciate your responding to questions online as well. Thank you so much. I'd now like to turn to our next speaker. We are very pleased to have with us Dr. Viorel Sultan from the Stop TB partnership. He heads the country and community support for impact team. Thank you for joining us, Viorel. So we'd like to ask you to share with us Stop TB partnership's work on civil society engagement and what efforts are being undertaken to address stigma and discrimination, including through gender and legal assessments. Over to you, Viorel.
Thank you, Monica. Thank you, Teresa and team for giving this opportunity to present our work at Stop TB Partnership. So I will follow the tradition. I have a few slides as my fellow panelists, so we'll try to share them quickly with you. Okay, I hope you see the slides. So just to remind ourselves about some targets and commitments that all of us are trying to push and achieve The last commitments we were speaking about, it was they were signed by at UN HLM by the heads of state in relation to end TB. And just to remind ourselves that there are commitments on communities' rights and gender, including those related to stigma and discrimination, access to medicines, overcoming legal barriers, gender equity, participation of TB key and vulnerable populations, psychosocial support, and equitable and human rights-based approach. So all our work is framed around all these topics. You remember that last time we supported, together with the civil society delegations to the Stop TB Partnership Board and over 150 partners around the globe, the complementary report around the situation in terms of where we are in relation to those commitments. And actually, partners looked through the situation, comparing are we able to reach those commitments, and the report came as a deadly divide between what we have and where we have to be. So we also will repeat this and plan to have a deadly divide exercise in 2023. So we'll have a deadly divide report 2.0. Our flagman program at Stop TB Partnership is called Challenge Facility for Civil Society. You see that up to now over 230 grants in more than 47 countries have been supported in all regions. We just closed the round 11 call, and soon we'll announce the winners as well. But just wanted to mention that the round 11 call is in totaling already 9 million to date. So we expect to put more money for challenge facility for civil society around the globe. In short, what the challenge facility is supporting in countries, these activities around human rights programming, community-led monitoring, advocacy, gender transformative interventions, community participation, reaching key and vulnerable populations, stigma elimination, social protection, women and girls empowerment. And of course, we aim to transform them in a sustainable interventions linked and budgeted, included in the national strategic plans of countries. And of course, we do a lot of we build a lot of evidence around this kind of activities in order to get more support for these interventions. We did an interesting exercise in terms of doing country community rights and gender assessments. We did these assessments in over 20 countries during a period of time, 2016-2020, and framed those around 7 dimensions of looking at barriers to services and why the systems are still missing people with TB to diagnose and treat. These findings have been published in peer-reviewed Harvard journal, and as I said, it's a good already platform in terms of building evidence around these findings. These are the countries that implemented the assessments, and you see they are distributed over 4 regions. In here you can see in short that majority reported stigma and discrimination as a biggest barrier to services. You see employment discrimination, you see discriminatory laws, lack of recognition of protection for privacy and confidentiality, and many other barriers to services. They have been mapped in a specific frame. So based on them, it's now much easier to design those interventions in order to reduce these barriers to services. Also, in our portfolio, we support community-led monitoring. We call it One Impact. It's a digital platform implemented by communities where a beneficiary of services can report back around a number of issues, including quality, accessibility, affordability, and of the services. Using these platforms will also be useful for to engage in math exercises at the country level. So currently we have One Impact basically present in 20 countries. You see the map here. So please use these platforms also when considering math exercises at the country level. We also have quite a number of tools to be included again in these exercises, like TB stigma assessment. I already told you about the community rights and gender assessments, One Impact community-led monitoring. Together with partners, we did a number of tools in relation to human rights, and you see them listed on the slide, including briefs on TB key populations, some papers on gender discussions, and so on. So all of them are available. I will share the slides with all of you. They have clear links, so please use these tools again for accountability processes at the country level. And I will stop here and happy to take any question. Thank you, and back to you, Monica.
Thank you very much, Viorel. Very comprehensive presentation, which already actually touches upon some of the questions raised in the previous session on what opportunities exist for resources. You highlighted your challenge facility, for example. Also, the importance of the assessments, the CRG assessments that you've done to look at what the gaps are, legal, on stigma, discrimination, human rights. I think all very critical, and also thank you for sharing those resources. We will post them online. Colleagues, please do post questions for Viorel on the Q&A function. So thanks so much, Viorel. We'd now like to turn to Bertrand Kampur, who is a member of WHO's Civil Society Task Force. Thank you so much, Bertrand, for joining us. We'd like to ask you to share with us, please, the experiences and perspectives of WHO Civil Society task force on advancing multi-sectoral engagement and accountability. Over to you, Bertrand.
Yeah, thank you, Monica. This presentation is made on behalf of the WHO Civil Society Task Force. The Civil Society Task Force is a diverse group of more 18 civil society experts in all the WHO region. So today we are happy to present our experiences and perspective on advancing multi-sectoral engagement and accountability. As you say, Monica, my name is Bertrand Campoer. I am from Cameroon in Francophone West and Central Africa. So our presentation is made mostly in terms of our key operation, what is part of the CSCF priority, but also in terms of what has been done in terms of our experiences. And we have an example from a specific initiative made in Western Central Africa, focusing in 12 countries. And also we have some of the perspective and the lesson learned and the challenge. In terms of the civil society task force priority, so for the past 2 years, we have a specific work plan with 6 priorities. This is also part of our priority for this year 2022. The first one is task force operation. The second point in terms of our priorities, accelerating progress on the UN Secretary General 10 priority. Third point is engaging, ensuring meaningful engagement with WHO at all levels and boosting engagement with national program. As my colleague was part of this call, remember that some of the challenge civil society has is mostly at country level, because at regional and global level, there are very strong collaboration between WHO and civil society. And the other point is strong engagement in TB guideline development and research at the global and country level. We also have engagement in MAF TB process. This is part of the topic today. And the last point, as part of the CSCF priorities, innovation and civil society engagement in TB-19 and TB response. So in terms of the engagement of TB processes, the Civil Society Task Force is mostly engaged in 2 specific areas. The first area is in terms of our engagement on WHO guidance document, but also our engagement in national and regional TB, MAF TB processes. In terms of our engagement on WHO guideline, we are happy to really deeply collaborate on Annex 2 of the baseline checklist. The checklist was along with the MAF-TB. So the checklist number 2 was really to assess the involvement of civil society organization on the 4 components of the MAF. Actually, we are also deeply involved on the MAF-TB operational guideline. This document was highlighted by my previous, those who, by Monica and other colleagues, but also the Civil Society Task Force also contributes on the case study document. The document was produced by WHO GTB by next month. In terms of engagement in national and regional processes, our colleague, member of the task force, was involved at national and regional level. For example, our colleague Ezio was involved on the assessment on Brazil. Professor Ali who was member of the Civil Society Task Force, was involved in the South Africa assessment. Our colleague Evaline was involved in Kenya. Also Jamila in Tajikistan. And my co-chair on the working group of the CSTF working group, MAF-TB working group, Jamila was part of the process in 5 European countries, but also myself was leading a process of assessment, regional assessment of TB in 12 countries in Western Central Africa. So experiences we have for the adaptation of MAV-TB in 12 countries in Western Central Africa. So 12 countries was selected, 12 Francophone Africa country was selected, and this was done by our regional partner, MAV-TB, in collaboration with the network of NTP in Western Central Africa, CAM and ONE-TB. So we conducted the assessment of the MAV-TB in 12 countries in Western Central Africa. It was to evaluate the 4 components of the MAV-TB. This was done in close collaboration with the WHO country office at country level in those 12 countries. And the methodology was the documentary review, meeting with NTP to fill the checklist, but we also use the software to analyze the data, and the data analyzed on the 4 components of the MAV-TB. So in terms of the commitment, the summary of the commitment in those 12 countries, on the first component of MAV commitment, planning initiated as 20%, action are in place on 34%, action need to be strengthened on 42%. In terms of the action, based on the 4 components of the MAV-TB, the action in the 12 countries, planning initiated in 19%, action are in place in 53%, action need to be strengthened in 33%. In terms of monitoring and reporting, planning initiated in 16%, action are in place in 38%, need to be strengthened in 80%. And also in terms of the review process, planning initiated in only 4%, action are in place 30%, and action need to be strengthened at 80%. And also, we also have evaluation of Annex 1, Annex 2, Annex 3. Annex 2 is part of civil society engagement, also evaluate part of these experiences. In terms of our perspective, so we need to, for this year, based on the recommendation of the first evaluation, we plan to put in place a dashboard using One Impact, adaptation of One Impact, to monitor the progress made on the 4 components, mostly in terms of commitment made by countries to progress to implement the action recommended on the MAV-TB. So give me 1 minute to highlight some key challenge and opportunity during that process. In terms of the challenge, we have four key challenges. The first one is that during the evaluation process, we realized that in most countries, LTP was discovered the first time, the MAV-TB tool. And also the second point is that after the evaluation, during the validation of country report, there was some misunderstanding between civil society organization and NTP in some area. But also there is a need for a standardized methodology for data analysis. And the last point in terms of the challenge is the limited funding for civil society engagement. And one of the opportunity and also part of this process. When the experiences was conducted in the 12 countries, we received a strong support in terms of clear specific training provided by the WHO GTB program. But also actually we have the WHO learning platform where country and individual, those who are interested stakeholders, can have information on how to implement the MAV-TB at country level. In terms of opportunity, we have around the misunderstanding between CSO and NTP in some area. During the process where we evaluated the MAV-TB in 12 countries, there was a lot of support from the WHO country office because there was also part of the game in terms of evaluating the findings made by NTP and civil society. And for the methodology, this is also what we plan to raise on the new operational guidelines, that there is software that can be used you can be used to have strong data. Also, part of the limited funding, there is opportunity with Stop TB Challenge Facility for civil society. For the action was made in Western Central Africa. So far for Challenge Facility around 9, around 10, we received around 250,000 US dollar, $100,000 for the round 9, and $150,000 for round 10. And we are expecting, as Dr. Joel said, that there's also, we are waiting for the results of round 11 because we also request funding from round 11 to sustain this work in Western Central Africa. So this is really a great opportunity for civil society to be engaged in this process. Again, on behalf of our civil society task force, I thank you, Monica, for this opportunity for the civil society force to communicate on our activities, experience, and perspective. Thank you, Monica. Bye-bye.
Thank you very much, Bertrand. Very clear, comprehensive presentation. Again, the Civil Society Task Force has been engaged with us right from the start, from the development of the multi-sectoral accountability framework to the various tools, as you presented, the checklist to implementation on the ground. Thanks for sharing all the various challenges, the opportunities. I think these are very good, and for also highlighting the various opportunities, especially through the new e-learning platform that we've launched, where you can build up your capacity by learning more of WHO guidelines and the rest, the latest guidance that's available. So thank you so much, Bertrand. We appreciate your support and that of the Civil Society Task Force. Again, colleagues, if you have questions, please post them on the Q&A function. And I would like to thank our panelists for all their interventions, really great presentations from across sectors, as well as engagement of course, civil society communities. We heard from IOM, ILO, from CSTF, from Bertrand and Stop TB Partnership. VRL, thank you, Chris, Didi, VRL, and Bertrand. Your inputs are much appreciated. And to all the attendees, thank you for all the questions. The panelists have been responding live. We're seeing that they're responding here. If not, we suggest also using the multi-sectoral accountability online platform that we have. If you have further questions, sign up, become a member of the network, and please share your questions, and we will work towards responding to those online. So we're at the end of the session. We promise to keep it as interactive as possible, and we asked you on Slido to post the various priorities, the important priorities, what you felt was, in your view or experience, is an important priority to facilitate MAF-TB, and we've got great responses from colleagues from Ethiopia about consultations, workshops. Ethel says political will and funding. The prioritization of young people and children. Financing keeps coming up again and again. Engaging top leadership, creating more awareness. Again, collaboration and engagement, increased advocacy, meaningful engagement of the community from ND. Integration, Kadir from Pakistan. A strong thing that comes throughout is, of course, political commitment. And Stephen says MAF is a vehicle in finding missing people with TB. So again, highlighting the importance of MAF. So we've had so many inputs. What we've done is We've collated all of these into a ranking poll, and we'd like to take maybe a few minutes of your time. If you could quickly rank, my colleague E has even grouped together some questions, some of the priorities that you've mentioned. Again, please go on Slido. You can use your phone to go online or type www.slido.com and with the password hashtag MAFTB, and we'd like you to rank what you think is a top, what will be really important in your view among the various priorities that are mentioned here. So we'd like you to take a quick minute, yes, to quickly mark what you think will be important. So there's political commitment, political will, engaging top leadership. So please go ahead and rank. We'd be grateful to hear your inputs. Okay, so right on top is, the people are responding now. Of course, up-to-date national strategic plan, creating more awareness, top engagement of top leadership. So what we'll do is, please do vote. Please sign in and vote. This is very important for us. What we can see as one of the major priorities, of course, is building more political will, engaging top leadership, financing. These are the ones that keep coming throughout. There's engagement with different sectors like workplaces, engagement of the community. All of these are indeed important, and we've taken note of these, especially as we're looking at operationalizing and working with countries to implement the operational guide for MAF-TB. So we urge you to continue your commitment and your support, especially as we look at taking MAF-TB to the next level in the lead up to the high-level meeting and towards ending TB to save lives and to reach those most in need, beyond just, of course, looking at the clinical aspects, but looking at all the social drivers of the epidemic. So we'll keep this poll open for you. And again, a reminder to please join our MAF-TB online network so that we can continue our conversation. I'd like to now turn to Dr. Teresa Kasayeva to deliver closing remarks.
So thank you very much, colleagues, for the time spent. I see we still have more than 140 participants online. For us, it means a lot. It means that this topic is extremely important and that we should continue our interaction. And indeed, we can see that this is a real platform where we can connect people and groups that maybe in the common life almost have no chances to meet, and that's why I would encourage you to follow our NTB forum, to continue interaction with us, and please let us know what will be the most useful and the best platform or approach for you, how to exchange this information and how jointly push forward the implementation of the multi-sectoral mechanism. And I fully agree that MAF is a real mechanism that will allow us to drive a further TB agenda. In the new era, with a lot of innovations, with the very dynamic world, we have no chances to succeed if we will continue doing business as usual and will look at TB only at like on medical problem without taking into consideration all the social determinants and drivers of the problem. we are receiving questions, and I see it's among the priorities that guidance, guidelines, best practices, examples will be needed as much as possible and as soon as possible. Yes, we are taking notes from this request, and we are committed doing our best to provide these guidelines. But in the same time, we should understand that once it comes to the practical implementation, we will hardly find two similar math at the country level, because we should take into consideration many specific aspects and due to each country. And beginning from the ways how to receive these high-level commitments, real commitments followed by real actions. Then we should identify, and you first of all at the country level, the real drivers of the whole process. Because we see already now, analyzing the baseline assessment and implementation, that in some countries, civil society community are playing a very clear and strong role of such drivers. In other countries, parliamentarians can also play important role. In other countries, the national TB programs, in many cases, they're playing this role. But in the same time, if national TB programs are not committed enough and not prioritizing, there could be serious issues with the further implementation. So let's try now to understand all together that this is the real way forward if we are serious about recovery of our services and providing further and more impressive progress. Now, we should also, it's important to identify other drivers, drivers as key social determinants in the countries that are influencing influencing TB epidemic in the country. And we know that there could be different determinants as HIV, other comorbidities, diabetes, but mainly poverty and undernutrition. And unfortunately, we can observe that the role of these determinants will be growing, and it means that the sectors responsible for addressing needs of the poorest people, some social support programs definitely should be involved in the MAF TB. So, of course, the list of the sectors, ministries, and stakeholders, again, could be different depending on the country context, but some essential minimum stakeholders should be there. Another question about a role of civil society and community. There could not be double opinion. This role is absolutely critical, and we can see even here at headquarters of WHO how meaningful engagement of civil society can change the whole dynamic. And that's why we are promoting and would like to encourage all of you to do the same. Also, one more point I would like to bring to your attention related to WHO guidelines. We are also trying to do a few other things besides of development of operational guidance specific for MAF-TB, to consolidate and to map all different already existing products, and not only developed by WHO, but also by other partners and stakeholders, to map how they can complement and respond to some specific and maybe more detailed questions on how to combat stigma, for example, how to provide the social support for vulnerable categories of populations, how to address needs of migrants and refugees. So that's why we should keep in mind that not only this product, which will be released hopefully soon, but also other products could be used and to cover in a comprehensive manner all our needs. So we will continue also learning lessons, and that's why best practices shared today and that we are planning to share in future. I think this is the best and concrete example how to do some certain things, and if there are already examples that are working, I think that it will be the fastest opportunity and the best to implement with some adjustments according to the country context. So HIV, COVID, and the lessons learned from the approaches how to the world addressed these epidemics would be helpful, but we should not forget that complexity and specificity of TB, its transmission. So not everything literally what worked successfully for COVID and HIV could be translated and used in TB. So learning lessons, consolidating efforts, sharing our knowledge and moving faster. These are essential requirements of the current momentum. And please share your feedback, what you would like to learn more, to hear more, and how we can, as WHO, address better your needs. And let's stay in touch. And I hope this interaction will be continued on a regular basis. Thank you.
Thank you, everyone, for joining us. Goodbye.